Ladies and gentlemen, for today's CPC, we have a very interesting, unique, and a rare case, and this will be presented by Dr. Sharda. Dr. Sharda will present the clinical protocol.
Thank you, sir. Good morning, everyone. In today's CPC, we will be discussing about Mr. AK, a 68-year-old gentleman from Ghaziabad, who was admitted under clinical hematology and medical oncology during April 2022 for a period of 10 days and died on 18th April. He had chief complaints of multiple villaceous plaques and nodules over scalp, forehead, neck, chest, abdomen, and extremities, along with painless swellings in neck and axilla for 6 months. He had loss of weight, which was not documented. Appetite was preserved. Generalized weakness and easy fatigability and shortness of breath on exertion for 2 months. He presented with epistaxis and subconjunctival hemorrhage for 1 day. There was no history of fever, night sweats, or pruritus. He was vaccinated against COVID-19 and he was a smoker. On physical examination, he had a pulse of 86, BP of 150/90, respiratory rate of 24, and saturation of 96% on room air. Subconjunctival hemorrhage was noted on examination. Bilateral cervical and axillary lymphadenopathy was present. Examiner noted multiple villaceous plaques and nodular lesions over scalp, forehead, trunk, upper and lower limbs. Abdominal examination revealed hepatosplenomegaly. Foley's catheter was noted in situ. Investigation showed severe anemia, thrombocytopenia, and leukocytosis. The differential count on automated counter showed 70 to 90% monocytes. However, on peripheral smear, this was reported as blasts of about 70%. ABG at admission showed respiratory alkalosis. However, later he developed metabolic acidosis and hyperkalemia. Coagulation profile showed INR of 1.29, which worsened to 1.65 on 16th April. Serum biochemistry showed deranged renal functions, which improved with treatment. However, again worsened preterminally with a urea of 117, creatinine of 5.7, and hyperkalemia. His phosphorus and corrected calcium were normal. He had hyperuricemia at admission, which improved with treatment. However, we do not have the records for last few days. His LDH was elevated. Liver function tests were essentially normal except for mild hypoalbuminemia. ECG showed a normal sinus rhythm at admission. HIV card test was negative. Ultrasound abdomen showed hepatosplenomegaly and lymphadenopathy in periportal and peripancreatic region. Serum protein electrophoresis was normal with no M band present. Coombs test was negative. Punch biopsy done at another medical college from upper chest skin lesion showed infiltration by atypical cells with cerebriform nuclei consistent with a diagnosis of mycosis fungoides, advanced stage. Now I invite Dr. Nidhi Prabhakar from radiology, followed by Dr. Pariksha Gupta from cytopathology and Dr. Navajit Malik from hematopathology to present their findings.
Good morning, everyone. There were 2 CTs done. The first CT was neck, chest and abdomen, contrast enhanced, which was done on 11th April. These are the neck and the chest sections, which show presence of multiple enlarged lymph nodes in the neck, in the cervical region, as well as in the axillary region, the mediastinum, as well as in the hyla. All these lymph nodes were homogeneous, with no evidence of any calcification necrosis seen within them. In addition, minimal left pleural effusion was seen. The lung window sections show few tiny nodules measuring about 2 to 8 millimeters seen in bilateral lungs. You can see. They were very few and non-specific with no evidence of any calcification in them. A note is made of a tiny lung cyst and parenchymal bands in the left lower lobe. The CCT abdomen section showed liver, which was enlarged and measured about 22 centimeter in craniocaudal span. And the spleen was heterogeneous in attenuation and measured 17 centimeter in craniocaudal span. The kidneys were also showing mildly heterogeneous nephrographic density with perinephric fat stranding. In addition, similar lymph nodes which were homogeneous were seen in the periportal, peripancreatic location and in the retroperitoneum. They were also seen in the pelvis along the iliac vessels and in bilateral inguinal region. In addition, there was a mild urinary bladder wall thickening with perivesical fat stranding. So overall on this CT, we had generalized lymphadenopathy involving cervical, axillary, mediastinal, abdominal, and inguinal region. These lymph nodes, like I said, did not show any calcification. They were homogeneous, which are normally seen in patients of lymphoma and leukemias, which would be further discussed by Dr. Saurabh. In addition, there was hepatosplenomegaly, mild left pleural effusion, and few non-specific tiny random nodules in bilateral lungs, which I will talk about later, and mild UV wall thickening and perivesical and perinephric fat stranding, which may be inflammatory or infective in nature. The CT chest, non-contrast CT chest, was repeated on 15th April. As compared to the previous scan, there were few areas, wedge-shaped areas of consolidations in the peripheral and subpleural location. In addition, there were appearance of new nodules, randomly distributed, and the tiny nodules which were seen initially were also seen in this scan, which had not undergone any change. These are the wedge-shaped areas of consolidation. And the lymphadenopathy was similar as seen in the previous CT. The left pleural effusion had resolved in this scan. So as compared to the previous CT, in this CT we have the pleural effusion resolved and new areas of subpleural areas of consolidation. They are peripheral and wedge-shaped. They may be seen in angioinvasive infection or also may be seen in infarcts. However, we do not have contrast-enhanced CT to comment on the pulmonary arteries. And there are new appearance of multiple nodules because if they've rapidly appeared, most likely representing infective etiology. However, there were few tiny nodules which had not undergone any change in the previous two CTs, so an underlying metastatic disease of the lung and also cannot be ruled out on the basis of these CT.
Good morning, everyone. So, final aspiration cytology in this patient was performed from bilateral cervical lymph nodes and the scalp swelling on 11th of April. The smears were highly cellular and they showed this predominantly dispersed population of atypical lymphoid cells. As we can see, as compared to small mature lymphocytes, these cells were 2 to 3.5 times the size, and they had high NC ratio with the round to irregular nuclear contours, opened up chromatin, and inconspicuous to variably conspicuous tiny nucleoli. There were multiple atypical mitotic figures scattered, and an important feature was the presence of these cytoplasmic blebs or these cytoplasmic processes like these. So they were noted frequently, and in addition, background showed degenerated lymphoid cells and lymphoglandular bodies. So this is the higher magnification. Here we can see these cytoplasmic blebs or the processes coming out of these cells, and these are the lymphoglandular bodies, which are basically the cytoplasmic fragments of these atypical lymphoid cells. This is a mature lymphocyte, and as compared to the size of a mature lymphocytes, these are quite large cells. So this is another area showing similar cytoplasmic processes and the large atypical lymphoid cells. Another area to show the atypical mitotic figures. This is the corresponding hematoxylin and eosin stain smear showing similar atypical lymphoid cells, similar nuclear as well as cytoplasmic features, and the atypical mitotic figures. So based on this cytomorphology, it was difficult for us to categorize it into a particular lymphoma or leukemia. So a diagnosis of infiltration by lymphoreticular malignancy was given with an advice to correlate with the hematological investigations. So cell block was also prepared for this case, and it was quite cellular and showed sheets of these similar atypical lymphoid cells. IHC, however, was not requested. How recently, in view of academic interest, it was performed, and we noted that these cells were diffusely positive for leukocyte common antigen or the CD45. However, they were negative for CD20, which highlighted only the occasional small mature B cells. And CD3 also highlighted the interspersed T cells, while they were negative for, while the atypical cells, they were negative for CD3. And they were also negative for 38, 138. Further, more stains are being conducted. And so final diagnosis still remains infiltration by lymphoreticular malignancy. Thank you.
Good morning, everyone. So, to the hematology department, we only received peripheral blood. No bone marrow was done, with the requisition of an elderly male who had multiple skin lesions and an outside diagnosis suggestive of mycosis fungoides. So the peripheral blood showed anemia with a hemoglobin of 6.9, marked thrombocytopenia with platelets of only 8,000, but there was leukocytosis with a TLC of 38,800, which consisted mainly of blasts, so 93% blasts in the peripheral blood. So these were the blasts in the circulation, the peripheral blood circulation. You can see that they are large in size. They are larger than the size of a neutrophil here. They have these opened up chromatin. You can see folded appearance of the nucleus. You can also appreciate these nucleoli in some of these cells. And you can also see some of these cells have cytoplasm, which show vacuolations in the cytoplasm. So when we took a closer look, we found some of these cells that Dr. Pariksha had also shown in the cytology smears. These cells having these cytoplasmic extensions from one end, forming pseudopodia-like extensions of these cells. These cells were myeloperoxidase negative. You can see a nice neutrophil showing MPO positivity in the form of these brownish pigmentation. However, this blast is negative for MPO. So to assess the character and the nature of these cells, we performed flow cytometric immunophenotyping, and we saw that most of the cells, 90% of the cells, were in the CD45 dim region. Here you can see these are the CD45 bright lymphocytes, and anything that is less bright than that is the CD45 dim, which basically is the precursor of the blast gate. So these are the blasts, which are 90% of all the cells in the peripheral blood. They are negative for B cell markers like CD19 and CD20, but they're also negative for the immaturity marker CD34. Some T cell markers were done. They're negative for CD3, however, they're dim positive for CD7. They were bright positive for CD4 and negative for CD8. They were clearly negative for CD2 and CD5. However, a small dim expression of CD5 was noted in these cells. Further, when we looked at myeloid markers, we saw that they were bright positive for HLA-DR, but only a small subset showed 117, so no very dim 117 expression. Other myeloid markers like CD13, CD15, CD33 were all negative, but to our surprise, these cells were nice and bright positive for CD123. They were also very positive for CD56. They were negative for monocytic markers like 14 and 64, and they were also negative for MPO and cytoplasmic CD3. Now, CD123 is basically the alpha chain of the interleukin 3 receptor, and only 2 cell lineages express CD123 at this level of brightness, which are basophils and plasmacytoid dendritic cells. So, to look at our database, we had on morphology around 93% blast-like cells, with some of them showing pseudopod-like cytoplasmic projections. On flow cytometric immunophenotyping, we had a population which was CD45 dim, CD45 dim, CD4 positive, 56 positive, and 123 positive, and also HLA-DR positive. These cells showed us dim expression of CD7, 5, and 117, and they were negative for other T myeloid and B lineage markers. So considering all this together, morphology, the presentation of skin nodules, and the positivity of the classic feature of CD4, 56, 123, and HLA-DR coming together, we made a diagnosis of blastic plasmacytoid dendritic cell neoplasm. Now, blastic plasmacytoid dendritic cell neoplasm is a very rare neoplasm, and if you see at the name, you can see that blastic suggests that it's immature in nature, and the cell of origin is plasmacytoid dendritic cell. So this is a blastic plasmacytoid dendritic cell neoplasm. It is a very rare neoplasm and not very well understood, which is reflected by the fact that in the 2008 WHO classification of these myeloid neoplasms, they were classified as a subgroup of AMLs. In the 2016 classification, they were made an independent entity altogether. But in the current WHO that has come out in 2022, they are now subcategorized as a part of histiocytic neoplasms. So, thank you.
In course and management, the patient was admitted. He was treated with hydration and febuxostat, received multiple blood component transfusions during the hospitalization. He developed fever 2 days after admission, which continued throughout the hospital stay. He was then treated with venetoclax, imipenem, vancomycin, and liposomal amphotericin B. In view of hypoxia, he was shifted to hematology HDU on 16th and started on non-invasive ventilation. Nephrology consultation was sought in view of acute kidney injury. Loop diuretics and antihyperkalemic measures were started. His condition continued to deteriorate with worsening hypoxia, and DNR orders were signed by the family. In view of hypotension, noradrenaline infusion was added on the last day. The patient died on 18th April. So in clinical database, we have a 68-year-old male smoker with multiple cutaneous lesions in the form of violaceous nodules and plaques, generalized lymphadenopathy and hepatosplenomegaly, weight loss, easy fatigability, mucosal bleeding, and during admission the patient developed fever and hypoxia. On investigations, we have severe anemia, thrombocytopenia, leukocytosis with 70% atypical lymphocytes, punch biopsy done at another hospital consistent with mycosis fungoides, FNAC from cervical nodes and scalp nodule showing infiltration by lymphoreticular malignancy, immunophenotyping suggestive of blastic plasma cytoid, dendritic cell neoplasm, and HRCT chest done on 15 showing multiple areas of consolidations and few nodules in bilateral lungs predominantly involving the right lung, along with acute kidney injury and hyperkalemia. So how do we approach this patient? For the primary disease, we have an older adult male with cutaneous nodules and lymphadenopathy, both of which are suggestive of infiltration by leukemia or lymphoma, along with hepatosplenomegaly, anemia, thrombocytopenia, suggestive of bone marrow infiltration, and circulating malignant cells. So we are dealing with a hematopoietic neoplasm. So a wide variety of hematopoietic neoplasms can present with cutaneous manifestations from AML, acute monocytic leukemias, myelodysplastic syndromes, MDS, MPNs, and myeloproliferative neoplasms, and B cell and T cell lymphoproliferative disorders. So the most relevant to our patients, when we see a patient for a non-hematologist, mycosis fungoid is what comes to mind. So we have an older adult patient with extensive cutaneous involvement involving sun-protected areas and punch biopsy showing atypical lymphocytes with cerebriform nuclei. However, the patient did not have a history of pre-mycotic period and pruritus. Sézary syndrome may present with generalized lymphadenopathy and circulating malignant cells in addition to cutaneous manifestations. However, pruritus is almost always present in patients with mycosis fungoides and Sézary syndrome, which was not the case in our patient. Adult T-cell leukemia is another close differential with skin lesions similar to mycosis fungoides. This is associated with the human T lymphotropic virus 1. The patients will have lymphadenopathy, hepatosplenomegaly, and circulating malignant cells, and the disease has an aggressive course. However, our patient did not have any lytic bone lesions or hypercalcemia. T-cell prolymphocytic leukemia will also present similarly along with skin infiltration, hepatosplenomegaly, and lymphadenopathy. It is a rare disorder and the patients usually have a marked leukocytosis which was absent in our patient. CLL is an unlikely diagnosis in a patient, although the patient had painless lymphadenopathy and skin infiltration may be due to leukemia cutis. The absence of B lymphocytosis and the presence of immature forms and an aggressive course point against a diagnosis of CLL. Chronic myelomonocytic leukemia can present in older individuals with peripheral blood monocytosis and nodular cutaneous leukemic infiltrates. However, by definition, the CMML blast count is less than 20%. Acute myeloid leukemia and monocytic leukemias also affect older individuals and present with anemia, thrombocytopenia, and circulating malignant cells. Skin infiltration may be explained by myeloid sarcoma or leukemia cutis. Generalized lymphadenopathy is rare in AML, and hepatosplenomegaly is present in less than 10% of patients. Blastic plasma cytoid dendritic cell neoplasm is a rare entity, predominantly affecting older men. Cutaneous lesions are present in more than 90% of patients. They may be of varying sizes and colors and occur in the form of nodules or plaques. They are non-pruritic. It frequently affects the bone marrow, with skin involvement preceding the marrow infiltration by 2 to 3 months. Anemia and thrombocytopenia and circulating malignant cells are present in 2/3 of patients. Lymph nodes are affected in half the patients, and spleen and liver are involved in 20%. The diagnosis is basically based on immunophenotyping. If the patient's atypical cells express CD4 and do not express T cell markers, B cell markers, myeloid and monocytic markers, they are assessed for expression of CD123. This is important because this is a target for novel therapy directed against CD123. The diagnosis is confirmed by expression of TCL1, CD303, and CD304. In our patient, the complications that developed during hospital admission were most likely due to a hospital-acquired infection, either from a catheter-associated urinary tract infection or a hospital-acquired pneumonia. The patient did not respond to broad-spectrum antibiotics, so we are suspecting multi-drug resistant organisms, likely carbapenem-resistant gram-negative bacilli or fungi. The lung consolidation in our patient may be due to hospital-acquired pneumonia. Invasive aspergillosis remains a possibility. The patient had an underlying hematological malignancy, did not respond to broad-spectrum antibiotics, although we do not have serum biomarkers available. COVID-19 seems an unlikely possibility, although the patient was admitted during the fourth wave. The patient was vaccinated, and the CT findings are not really suggestive of COVID. Pulmonary thromboembolism is also a possibility. The patient was hospitalized for more than a week, developed hypoxia and hypotension preterminally. We do not have D-dimers or CT pulmonary angio available. Infiltration by blastic plasma cytoid dendritic cell neoplasm in the lung has been reported, but is extremely rare. Acute kidney injury in our patient was most likely multifactorial, with sepsis being the precipitating factor and nephrotoxic drugs, vancomycin and amphotericin B probably contributing to injury. Although liposomal amphotericin B is associated with lower risk of acute tubular injury, it is still present in more than 15% patients who receive liposomal amphotericin B. TLS remains an unlikely possibility, although we do not have uric acid, phosphorus and calcium values for the last few days. However, it cannot be ruled out. The patient did have hyperkalemia and acute kidney injury. The final diagnosis in a patient is blastic plasma cytoid dendritic cell neoplasm, hospital-acquired infection, sepsis, likely due to carbapenem-resistant gram-negative bacilli. Invasive fungal infections remain a possibility. Acute kidney injury was most likely multifactorial, with acute tubular injury from sepsis and nephrotoxic drugs. Thank you.
Thank you, Saurabh. Now you can come and join me here. In fact, it's such a rare and unique case that I don't think that many of us would be familiar with this type of neoplasm, which is blastic plasmacytoid dendritic cell lymphoma. So, barring hematologists and some of the people who deal with this, it'll be very difficult to diagnose this type of condition just based on histology. I believe that the diagnostic test in this situation is immunophenotypic. So, can I request the unit who was treating this patient to have the comments if they want to add what was the thinking, whether it was really mycosis fungoides or something else. I can see Dipesh. Dipesh, you want to? And frankly, if somebody doesn't do immunophenotyping, which is naturally done nowadays, the differential diagnosis would be that of mycosis fungoides, or?
Actually speaking, we are also not much wiser in this case because we were discussing this patient for bedside. This came up just as a last differential, and this is one of the very rare diagnoses. This is in fact my first case that I've seen. And this is a very difficult diagnosis to treat as well. So it's a very aggressive disease. The newest targeted drugs, anti-CD123, Tagarax is not available in India. And other treatments, even with other treatments, the survival is less than 1 year. But clinically, looking at the picture, it all fits into the diagnosis of BPDCN.
No, I was just asking, if such a patient comes to you, what will be your first possibility? Like mycosis fungoides would be...
Yeah, we discussed all the cutaneous infiltrations by leukemias that Dr. Sharda already discussed.
Yes, thank you. Now the case is open for discussion. Can we have comments from hematologists or cytologists? Now you have the immunophenotyping, so the cytologist would agree that the diagnosis of blastic plasmacytoid dendritic neoplasm, or what is the cell of the origin? Does it come from, is it a histiocyte, or does it come from marrow or node, or from where?
The dendritic cell is the cell of origin as till now, and we would agree with the diagnosis. So although we have not done the flow cytometry on this particular sample, but the characteristic cytomorphological features of those cytoplasmic tails and processes, the few cases that have been described, they are showing those features, and the morphology fits well with that.
Yes, thank you. Yes, Manubdesh. I think I can see Pankaj also, so maybe, you can comment on that.
Yeah, so in our experience, I would remember probably 4 cases, 1 pediatric, 3 adults. there might be one or two more, which we have diagnosed through flow cytometry. So diagnosis basically on immunophenotyping. There is definitely a sort of gene signature to this cell, and you can do more to diagnose if you have. The cell of origin is basically a sort of histiocytic monocytic lineage cell only, but they can originate, these plasma cytodendritic cells can originate from a common lymphoid progenitor as well as a common myeloid progenitor, depending on what transcription factors they get. So basically you are looking into a monocytic histiocytic lineage cells, but with a distinct nature from usual monocytic or a usual histiocytic cell. Yeah. Thank you.
Yes, Dr. Pankaj.
Good morning. So as has already been said, this is a rare kind of hematopoietic malignancy, and we don't see so many cases. But I always say, take the positive point of it. One soldier called his commander and said, "Sir, I am surrounded by enemies from all the directions." So he said, "Very good, you can fire in any direction." So similarly, in this also, when we don't have a particular kind of a clear lineage, so it is up to you to give any form of treatment. So you can treat by lymphoid, anti-lymphoid treatment, you can treat by anti-myeloid treatment. Fortunately, we now have a very good targeted drug which is directed against the anti-CD123, and one of the Indian origin Dr. Naveen Premraju is the one who has worked a lot on this form of malignancy, and he is one of the authority. In fact, this patient's son was in USA, and we wrote to him also about his opinion, and the problem is that drug is quite costly. So we treated with another drug which is BCL2 inhibitor, venetoclax, but this patient was quite old and he has so many other comorbidities, so that's why he did not survive much. But this was quite interesting and rare kind of a presentation. Thank you.
Yes, Aryan. There are new types of cells now we are finding in circulation, because classically, there were myeloid cells, lymphoid cells, now these are dendritic cells, histiocytic cells. I don't know, because I don't think malignancy follows a defined rule.
So two comments. One, his cutaneous findings were kind of characteristic for those people who are who are aware of this disease, those fiery red diffuse skin lesions, and people may and hematologists are being more and more sensitized towards this disease. That is one thing. The other thing is regarding the cell of origin. So the genomic profile, this patient on NGS had ASXL1 mutation, which is again a myeloid monocytic lineage mutation, and in BPDC, and although there is less data, but almost 42% of the patients harbor that mutation, and that report was collected post-mortem. So just wanted to add that as well.
Yes, please.
So we discussed that CD123 as one of the most important markers in diagnosis of BPDCN, but CD123 can also be expressed in various other leukemias, especially BALLs and also AMLs. So the bright nature of expression of CD123 is what sets it apart from those other neoplasms. So other markers like CD303 especially is a very, very specific marker for this lineage, plasmacytoid dendritic cell lineage, as also CD304 is quite sensitive. What we also need to remember is that as Dr. Aryan said, myeloid classification can be classified as myeloid and had previously been classified as myeloid as well, but since it is very the classification is still unsure, we really don't really know much about the cell of lineage. It is shifting from one class to the other over the years of classification. Thank you. And also, as we move into this group of neoplasms of plasmacytoid dendritic cells, there is a blastic BPDCN which we discussed. There is also mature plasmacytoid dendritic cell neoplasm. And to differentiate them, we need clinical profile, of course, that these are more clinically aggressive, but the immunophenotype can be almost exactly similar. So it will be very, very difficult to distinguish those two entities, the mature plasmacytoid dendritic cell neoplasms from the blastic ones.
Thank you. Yes, Vivek. Dr. Vivek. There were plenty of people who have called. Yes. The second issue is that of organ infiltration bar infection. So possibly you'll talk about the kidney.
Yeah, so if you look at his serial serum creatinine, for the initial 1 week, it was in the range of 1.5 to 2 only. So at that time, we would have made a diagnosis of most likely an RPRF-like state, and the most, I would say, given the kind of involvement that we have, so it would not be unusual to see infiltration by the neoplasm in the kidneys as the, I would say, the initial event, and subsequently towards the end, he had sepsis, shock, and other things, which led to superimposed acute kidney injury. Now we had, peripheral wedge-shaped lesions in the lungs in the second CT, and if we have in the CT which was shown here, I'm not sure, I may be overinterpreting, but it looked like, were there any focal lesions in the kidney also? So if there are focal lesions in the kidney, patient is running high-grade fever, then I think a possibility of infective endocarditis in such setting also should be.
Yes, yes, Dr. Kim, please. And the final thing was hypoxia. So I was wondering whether there was a leukostasis or infection, because infection CT-wise is not too much.
Actually may not be really related to this case directly, but one of my ICMR project which I had worked on, dendritic cell, role of dendritic cells in celiac disease pathobiology, I had used CD11C as a marker for those plasmacytoid dendritic cells. So nobody really talking about it. That was a good marker. We had very good result.
Yes, please. And that will be the last comment for the clinical protocol.
One of the cases from the department, we saw bone marrow infiltration by blastic neoplasm with rosette formation. So it will be interesting if there was something in this case. So we published that case. And the second thing was the ASLX1 mutation that was seen in this patient. That might be a chip-related mutation that is commonly present at 70 years, maybe associated with the clonal hematopoiesis rather than per se with the disease. Thank you.
Now it's my pleasure to invite Dr. Mayu to show us the pathological findings.
Good morning, everybody. A partial autopsy was performed on a 68-year-old male patient with a hospital stay of 9 days and a clinical diagnosis of type 1 respiratory failure, hospital-acquired pneumonia, and blastic plasmacytoid dendritic cell neoplasm, that is BPDCN. The prosector noted that the disease was moderately built and had multiple skin lesions in the form of plaque and patches all over the body. The largest was measuring 5 by 3 centimeter, which was seen located over the forehead. Serous cavities are within normal limit. We received the antemortem skin biopsy in the same month. The skin biopsy examined shows epidermis and dermis. The dermis throughout shows nodular aggregate. These nodular aggregates were dominantly seen located surrounding the vascular channels. The epidermis was unremarkable and does not show involvement. This is the higher power view to appreciate that these nodular aggregates comprises of monotonous infiltrate of the immature blast cells with many apoptotic debris in the background. Similarly, the postmortem skin examined also showed the nodular aggregates throughout the dermis with extension into the underlying subcutis. The epidermis and the adnexal structure was spared in this biopsy. This infiltrate was seen predominantly surrounding the vascular channels. At places they were located in perineural in location, and as well as they were showing this septal as well as lobular infiltrate into the underlying subcutis. This is the higher power view where you can appreciate the nature of the blast cells. They are monotonous and are of medium size, and they contains the oval nuclei with fine granular chromatin, inconspicuous nuclei predominantly, while few were showing small distinct nuclei with slight irregular nuclear membrane and hardly visible cytoplasm. Even many apoptotic bodies can be appreciated in the background. It was immunophenotypically on the flow cytometry. It was given suggestive of BPDCN, so we performed the assay panel accordingly. So these neoplastic cells were diffusely and strongly positive for CD45. They were negative for CD3, CD20, and it was diffusely positive for CD4. CD123 is the marker of plasmacytoid dendritic cell. It was nicely positive in these immature blast cells, while CD56 was also weak to moderately positive in these cells. So the diagnosis of BPDCN was kept. The postmortem imprint as well as the smears prepared from the bone marrow, it was highly cellular, and it contains these immature blast cells which are dispersed singly. This is the higher power view to appreciate the morphology of these blast cells. These cells had high NC ratio with round to oval nuclei, open up chromatin, slight nuclear irregularity. Some of them were showing small distinct nuclei, basophilic cytoplasm, and the cytoplasm are showing characteristic single to multiple vacuolations. In addition, few of these cells showed pseudopore formation. The postmortem peripheral blood smear prepared also showed few scattered blast cells with similar morphology as discussed in the bone marrow. The postmortem bone marrow appears hypercellular and shows diffuse infiltration of these immature blast cells, which are seen diffusely, and they are causing the marked reduction in the native trilineage hematopoietic elements. This is the higher power view to appreciate the immature cells as the medium-sized blast cells with inconspicuous nuclei and hardly visible cytoplasm. In the background, there is evidence of secondary hemophagocytosis. The lymph nodes were enlarged throughout the body, and these they were ranging in size from 1 to 3.5 centimeter. This is the lymph nodes which are present in the hilum of the lung. These are the retroperitoneal lymph nodes at the level of the kidney, and these are the perigastric lymph nodes. Most of the lymph node dissected were non-hemorrhagic, and they showed diffuse effacement of the lymph node architecture by the immature cells. While few of them, especially in the peripancreatic region, they were hemorrhagic dominantly. There was perinodal extension, and the morphology was similar as the bone marrow with medium-sized blast cells. In addition, there was evidence of hemophagocytosis in the background. The other reticular endothelial organs like liver also was enlarged and heavy, weighing around 2.5 kg. Grossly, the cut surface does not reveal any definite nodular or infarcted areas. However, on closer view, we can appreciate there is alternate dark and yellowish areas. So the microscopically, the scanner image shows maintained lobular architecture. However, there is evidence of this serpentinous growth pattern because of the infiltration by the leukemic cells, and they are mostly located in the portal region, portal tract, and at some places in the centrozonal region, and they are connected to each other. The capsular aspect of the liver also appears blotchy and shows alternate dark and yellowish areas. On microscopically, there is diffuse infiltration of the cells just beneath the capsule, as also it is seen extending transcapsular into the adjacent attached adipose tissue. On Mason trichome stain, we can appreciate the serpentinous growth pattern. Here, the expansion of the portal tract is usually due to the infiltration of the neoplastic cells rather than the fibrosis, which is not seen on the empty stain. Reticulin stain highlights the reticulin-rich area in the infiltrating blast areas. However, the framework was maintained in the adjacent lobular parenchyma. The portal tract, here we can appreciate the portal tract is expanded. It is showing collection of these immature cells, and in addition, it is seen connected with the adjacent portal tracts. However, there was no definite evidence of any sinusoidal growth pattern. The bile duct which were present in the portal tract, they were intact, and they were nicely highlighted on CK7. In addition, there were mild ductular reaction present in the background. This is CD45, which is nicely highlighting this serpentinous growth pattern with strong and diffuse immunoreactivity. CD3 and CD20 was negative in these cells. CD4 was positive diffusely. CD123 showed weak to moderate intensity. CD56 showed PASI positivity. MP was done, which was negative. CMYC was performed, which was also negative. CMYC is usually expressed in the cells which shows immunoblastoid morphology with prominent nuclei, which was not seen in this case. BCL2 was diffusely and strongly expressed in these neoplastic cells. In addition, the ductal structure at the septal level also showed transmural infiltration, where the infiltrate was seen limited to the basement membrane, with intact lining epithelium. And the portal vein were also being infiltrated by these immature cells with the lifting of the endothelial cells. The spleen was enlarged and weighs around 760 grams. The capsular aspect was blotchy, and one foci, there was one area showing the yellowish, well-demarcated lesion measuring 2.2 by 2 centimeter, which on slicing appears waist-shaped infarcted area. as this is the capsular aspect. Similarly, here also there was diffuse infiltration just beneath the capsule in the splenic parenchyma. The cut surface of the spleen appears a solid grayish, and with intervening small dark nodules, which was ranging in size from 0.1 to 0.7 centimeter. These dark nodules on scanner microscopically represented the blood legs. The infiltration of these immature cells was seen both in the red as well as the white pulp. In fact, the red pulp, it was completely replaced by these neoplastic cells, which you can see these cells, which is seen surrounding the arterioles, are positive for the CD123. Here also there was evidence of secondary hemophagocytosis. In addition to this infiltration, there were apoptotic debris which were present predominantly in the trabeculae. The section from the infected areas microscopically confirm its presence, which you can see there is a large necro-infected area which is sharply demarcated from the adjacent viable splenic parenchyma. There was foci of extramedullary hematopoiesis in the form of megakaryocytes, which are nicely highlighted on CT61. Similar EMH foci was also noted in the lymph node. We have submitted the tissue or liver tissue for the electron microscopy to look for any ultrastructure findings. These cells on electron microscopy, here we can appreciate the nucleus, which is showing slight nuclear irregularity with indentation, clumping of the chromatin, and lack of cytoplasmic dendrites. The cytoplasm is showing numerous rough endoplasmic reticulum with solen of mitochondrial. Coming to the thoracic system, this is the organ complex comprising of tracheobronchial tree and both left and right lungs. Both left and right lungs weighs around 1,350 grams. The pleura is dull at places. No fibrin tags were identified. The cut surface of the lung parenchyma throughout was firm and subcrepitant to fill. No definite areas of any consolidation or infected areas were identified. The mucosal aspect of the tracheobronchial tree showed many foci of this blackish discoloration. They were forming as if they were forming like a membrane, and sections were taken from these areas. This section microscopically shows diffuse infiltrate of these blast cells, which are seen invading and entrapping the underlying tracheal cartilage. This infiltrate, similar infiltrate, was present in the rest of the bronchus region, transmurally extending. The section examined from the lung parenchyma, which was firm, also showed evidence of infiltrate, which was predominantly seen in the bronchocentric region, destroying the native structures. And they were seen extending into the surrounding alveolar septa, causing its thickness, causing thickening of the septa with evidence of leukostasis. These infiltrate were also seen occupying, involving and occupying the alveolar spaces, and also seen involving the pulmonary artery as well as the intraacinar arteries. They were seen transmurally extending and causing lifting of the endothelial cells of the pulmonary artery. In addition, remaining section from the adjacent remaining lung parenchyma also showed areas of diffuse alveolar hemorrhage, pulmonary edema, and presence of these fibrin balls within the alveolar spaces, which are nicely highlighted on the Marshall Scarlet blue stain. The weight, the heart was enlarged and weighed around 440 grams. There was increase in the epicardial fat deposition. This is the right atrium, which is showing focal wrinkling of the endocardium with hemodynamic changes. The right ventricular wall thickness was 0.6 centimeter, which was within normal limit. The left atrium shows a wrinkling of the endocardium with hemodynamic changes. The left ventricular wall thickness was 1.8 centimeter, which was more as compared to the normal range. The left outflow tract showed grade 3 atherosclerotic changes in the base of the aorta as well as the ascending aorta. These atherosclerotic changes were seen extending into the opening of the right and left coronaries as well as the aortic cusp, as well as it is seen extending on the endocardial aspect of the left ventricular cavity. There was concentric hypertrophy of the left ventricle. We took sections and that showed moderate anisonucleosis with focal disarray. There was diffuse deposition of this yellow-brown pigment in the cardiac muscle cells, which was indicative of lipofuscin pigment. One of the section, especially in the endocardial region, showed collection of these neoplastic, these immature blast cells surrounding the vascular channels with some apoptotic debris. Similar infiltrate further we found on the epicardial aspect. as well as in the form of leukostasis within the myocardium. The coronaries were dissected, and all the right coronary, left as well as anterior and left circumflex showed the evidence of atherosclerosis with calcification. The right coronary was dominantly affected, and it showed the occlusion of around 80 to 90%. This is the organ complex comprising of abdominal aorta, inferior vena cava, both left and right kidneys, bilateral ureters, and the urinary bladder. Abdominal aorta showed the grade 3 atherosclerotic changes in the form of calcification, calcified plaques, which was seen involving both the left and right common iliac arteries. However, the right and left renal arteries were patent. Both left and right kidney weighs around 320 grams. The capsular aspect, the capsule is easily stripped off. However, the capsular aspect of the kidneys appear blotchy and showed the evidence of cortical foci of multiple cortical scarring. On slicing, the cut surface shows indistinct corticomedullary junction. However, there was no definite focal or any infected areas identified. This is the scanner view to show the evidence of infiltration, which is diffuse and seen involving the cortex, and also it is seen extending into the underlying medulla as well as the renal sinus. The glomeruli, in the most of the area, the glomeruli were congested, and the surrounding tubules showed changes of ATN. The interstitial infiltrate was seen dissecting and replacing the tubules. The morphology is similar to the as previously discussed. In addition, this infiltrate was also seen involving the blood vessels, which at the junction of the cortex and the medulla, that the arcuate vein was involved and infiltrated by these blastic cells. Adrenal gland was enlarged. Majority of the adrenal parenchyma was replaced by the infiltrate in the form of this tan brown deposit. Section examined from this adrenal gland showed the evidence of infiltration in the form of sinusoidal growth pattern and aggregates. This infiltrate was seen extending into the periadrenal soft tissue. There was lack of zonation of the cortical region of the adrenal cortex, and these cells were intensely eosinophilic due to loss of fat. Grossly, the stomach does not show any definite nodularity. However, microscopically, there was evidence of infiltration at the GE junction. The small intestine showed presence of mucus diverticulum measuring 3 by 2 centimeter, which also showed evidence of this grayish yellowish deposit. The mucosal aspect in the small intestine showed scattered presence of this broad-based polypoidal lesion, which was ranging in size from 0.8 to 1 centimeter, and showed central ulceration, which is with surrounded elevated mucosa. Section examined from these areas shows this polypoidal lesion with the overlying mucosal ulceration. These lesions also show the infiltration by these blast cells, which was seen extending transmurally from the lamina propria to the submucosa and involving the muscularis propria. Similar polypoidal lesions were also noted in the large intestine scattered singly, and they were ranging in size from 0.8 to 1.3 centimeter. They were broad-based, and few of them showed overlying mucosal ulceration. Microscopically also we can appreciate there is a diffuse infiltration of these blast cells, which is seen transmurally extending into the pericolorectal tissue with the overlying mucosal ulceration and some correctional bacterial colonies. The infiltrate is seen dissecting and replacing the muscularis propria, and the nature of the morphology is similar to that of bone marrow aspirate. Grossly, the pancreas was not showing any significant pathology. However, microscopically, it showed the evidence of chronic pancreatitis in the form of interlobular fibrosis. One of the sections showed the presence of this infiltrate, which is seen replacing the parenchyma with the preservation of the islets of Langerhans. The infiltration was also seen in the section examined from the urinary bladder, testis, thyroid gland. So in this case, in a 68-year-old male, a known case of BPDCN with type 1 respiratory failure, hospital-acquired pneumonia, blastic plasmacytoid dendritic cell neoplasm with multi-organ dissemination. The probable primary site could be skin. The dissemination is seen involving the bone marrow, lymph node, liver, spleen, pancreas, lungs, heart, kidneys, adrenal glands, GIT, testes, and thyroid gland. There is secondary hemophagocytic lymphohistiocytosis and extramedullary hematopoiesis. BPDCN, as already mentioned by Dr. Nabjisaki, it is initially was considered as a part of AML. Later on in 2016, it was considered as a distinct entity. However, in the recent 2005th edition of the WHO classification of the hematolymphoid tumor, it has been considered under the histiocytic and dendritic cell neoplasm as a distinct entity. Maybe due to the clonality, it mimics like one of the subset of the conventional dendritic cells. BPDCN, they are usually derived from the resting non-activated plasmacytoid dendritic cells with the aberrant NF-kappa beta pathway. The normal microenvironment of the skin does not contain these plasmacytoid dendritic cell. However, why these cells migrate? These usually is due to the expression of these antigens such as SCLA and CD56 and the production of chemokines expressed by the tumor cells. They causes skin migration of these plasmacytoid dendritic cells. Thank you.
Thank you, Mayur. Now, Mayur and Dr. Sharda, please come and join me. Now, both the clinical and the pathology protocol are open for discussion. In fact, there are plenty of questions, I'm pretty sure about it, that hematopathologist, the clinical hematologist would raise. Well, did you find any evidence of infection at all, or there was no infection? It was all just infiltration. Yeah, so there was no infection. In fact, this is, yes. Dr. Jagdish, you wanted to say something? Oh, okay. All right. Hey, Dr. Jasmina, would you like to comment? It's okay. Anybody else would like to comment that everybody agrees that the basic diagnosis is right, or, there are some discrepancy? Because to non-pathologists, at least in the spleen when he was showing 123, I doubt very much that it was 123 because he knows that is positive. Because at least the picture which was shown, I was not very convinced that the spleen was, the cells were positive for 123.
Sir, it was weak to moderately positive.
Well, let us be frank about it. No, in the sense that if this slide is given without, we try to fit a diagnosis, because please remember, my point is not that we are not dealing. My point is this, that, such cases are so rare, and what exactly happens is very difficult. Yes. Yes, doctor.
Mayur, spleen, those cells could be just AMH cells. He's been anemic for so long. I know that our department, AMH has been all the time, including mantle cell lymphoma have been made in the spleen. So I think could be just AMH cells. Actually, I had come to make about the primary site. It may be difficult in this case now because it's extensive disseminated disease process, because the skin possibly was also involved quite extensively, but we know that these cells is hemopoietic in origin, and the bone marrow was quite extensively involved. So I think the best is to fit into the most likely primary site as the site of origin, rather than suggesting something which is rare and out of the way. So possibly it's marrow in origin.
Yes, one of them. This type of discrepancy, because finally we are on the signatures of the cells which are present on the surfaces. That is giving us the clue. Can we go beyond that, or?
Yes, you have other markers like CD303, 304. They are quite specific for this lineage of cells. 123, as far as flow is concerned, is not of any doubt. It's bright homogeneous. There might be discrepancies in IHCs. The clone and the other stainings, other procedural things might be different in this scenario. But on flow, this is 123 bright positive, 4 bright positive, 56 bright positive. The plasmacytoid dendritic cell is a native cell to bone marrow. It is there, a very rare cell in general. It's probably less than 0.1% of the usual bone marrow cells. In normal cell expresses CD4, 123. It does not express 56 normally. So aberrancies induce 56 there, which causes migration to skin. So it is not primarily a skin origin tumor. It is a native cell. The cell of origin resides in bone marrow. This cell is different from the other dendritic cells. So the tissue dendritic cells are again classified into multiple types, depending on their how they develop from various transcription factors. As far as CD11C is concerned, in hematopoietic environment, CD11C is present in very high intensities in most of the monocytic lineage cells. So all AML's monocytic lineage will be bright 11C positive. Besides, there will be other lymphomas, especially hairy cell lymphomas, which are bright 11C positive, and there are various others which can infrequently expressed bright 11C as far as hematological environment is concerned malignancies. For this tumor, 11C is not specific and may be negative. The plasmacytoid dendritic cell neoplasm. Right. Thank you.
Yes, say something. Well, are these dendritic cells same everywhere, which is, normally because it is, we get the skin dendritic cells from the marrow dendritic cells.
Yes, my comment is regarding, as Navjeet described, so there are two forms of this disease. One is the mature one and another is the blastic. So blastic is this classical case which has given us the morphological landscape of the disease, and the mature ones are usually seen associated with your chronic myelomonocytic leukemia in the just as a nodule formation or in cases of acute monocytic leukemias. My comment is, Mayur, have you attempted to do KI on this case, because it has been shown that blastic cases have a higher KI than the normal, than the mature ones?
No, sir.
Yes, Dr.
You can attempt.
Will you like to, please just don't go by the signatures. Please look at the clinical parameters as well. Finally, you have to treat the person.
I think
and actually I'm getting confused. On
Yes.
one hand, somebody is saying lymphoid cells, somebody is saying myeloid cells, and then finally dendritic cells. Even WHO keeps on shifting. Well, that is how we would treat.
so. So
Who
that's
are
what,
they? Who are they? They are we actually.
So we have thoroughly confused you, but the good thing in hematology is that these days we have therapies which are directed towards the particular antigen kind of a thing. So, if it is expressing 123, so you are making a therapy which is directed against the 123. This patient had a BCL2, very good expression of BCL2, and as we said, we had given him a drug which is called venetoclax, which acts against the BCL2 inhibitor. So, the classification will keep on changing depending upon, how, with the advancement in the new markers, these 303, 304 right now are not here, but probably the Department of Hematology will procure that in future, and we will have, further sub-classification of even blastic dendritic cell neoplasm. So those will keep on happening, but the therapy will be directed towards the particular clone, and this is the beauty of hematology practice. Thank you.
Yes. Doctor, yes. No, just a minute, yes. We have, first of all, a young hematologist. Dr. Amit, I'm just provoking you. You believe that all these surface markers are enough to diagnose a disease or treat a disease? Because finally, these are just the expressions. They do not tell you about the clone. They just tell you the expression.
So, first of all, great presentation and demonstration of the pathology, Mayur. What we're seeing is basically the natural disease course of the disease, which is an aggressive, and this is what happens when you have an aggressive hematological malignancy which goes untreated for 6 months. It spreads everywhere. And this is why autopsies are important. And we've seen time and again in this hall, in the student and the staff CPCs, that where we are treating infections and it turns out to be just disseminated disease. Often, obviously, infections will remain the differential and you have to treat for them, but also it makes us wiser that when we are treating them, possibly it's just the disease manifestation which has spread everywhere and not just infection.
Yes, Dr. Kim, you wanted to say something.
We call cells malignant because they become malignant. They are unpredictable. They start expressing many things. Till the time you do a staining, a marker, you do not really know whether that is going to be positive or that is going to be negative. I do not really have any contradiction to the markers you have expressed. But what I was just saying that you have not done that particular one. So I don't think one needs to overreact to that. Do it and see whether it's positive or negative. That's all.
Yes, please.
I think this entity is very rare, and considering the extensive involvement of BPDCN like this all over the body, I think labeling the disease as a neoplasm, because neoplasm includes both benign and malignant. So ideally the term should be blastic plasmacytoid dendritic malignancy or blastic plasmacytoid dendritic leukemia, considering the level of infiltration. WHO may change the name in future.
What I'm saying about this name, look at from a novice point of view, from absolutely blastic, plasmacytoid, dendritic. than lymphoma. You know, you have added 4 diseases of different, absolutely. I think this is, to me, it does not make any sense. Yes, please.
I think we have become very senior. I think our institute, I should say, is, nowhere else would find an institute like ours, where we are dealing with cases like this day in and day out. This is a routine for us. I don't think anybody has access like the way we have access to. But the only thing we lack is confidence and faith on each other. We wait for somebody else to come up and report, because I had faced the same thing with villus atrophy in case of celiac disease cases, maybe 20 years back. I can name him the person who used to create problem for me, but Ujjar Poddar. I had so much of problem with him. And so I think we had to have the confidence on ourselves, on our colleagues. We are doing much better than anybody else. Lacking is confidence. And we have to have faith on each other. That's what I want to say as a senior faculty of this institute.
Thank you. Any other comment? Okay. Thank you, everybody.